All right. Hello to my LPN students, and our skill for today that I'm going to demonstrate for you is blood administration. Blood administration is a skill that we need to be very careful with. There are multiple checks that we have to do in order to administer blood or blood products. And so we've got to be diligent in these safety checks that we do. We cannot, dismiss one. We cannot allow ourselves to get in such a hurry that we don't pay attention and do each and every one of these checks. Even though they may be redundant over and over and over, statistics show that it's when the nurses do not do all of the safety checks, that's when a mistake happens. Um, there are lots of different types of blood products, whole blood, packed red cells, plasma, platelets. I mean, the list could go on and on. We want to make sure that whatever we get, that we are safe for these products. So to get started, you want to there's about 8 things that I always like to teach my students and make sure that you verify and check so that everything goes well and we keep the patient safe. If the patient gets the wrong blood, a hemolytic blood reaction, that means that the patient got the wrong blood. There is medications that we will give. There are things that we will do. It's not likely that the patient would die from that, but the potential is there that if we didn't react quick enough, do the right things, that is a possibility. All right, so 8 things that I want you to know, all right, absolutely know and learn. And so the first thing that we need to know is that we have a doctor's orders to give blood to this patient. So you want to make sure that you verify your patient by 2 means. You want to make sure that you look at your doctor's orders and that you have an order to administer or give that blood product, not that it says type and cross 2 units packed red cells. Nowhere in there do we have an action verb word that means we're to give it. So that just means the doctor wants it typed and crossed. Maybe this patient's going for surgery in the morning or something like that. So we want to make sure that we have an action verb in that order that says administer, give, a unit of blood or something like that. So verify that. Also verify the time in the order. You have a maximum time limit of 4 hours to get blood in. If this blood product that you hang goes over or starts to go over, we're not going to let it go over 4 hours. If it starts to go over that 4 hour mark, you've got to stop it. And then notify the physician how much was left and what caused it to be slower or whatever. So you want to make sure that you know how fast you're supposed to put it in, but you have a maximum length cutoff time of 4 hours. So that's number 1. Number 2, it's always good to ask the patient, have you ever had blood before? So ask them their history. If they say no, then continue on. If they say yes, ask them how they did with that. Did you have any problems with that? Any itching, rash developed? Was there anything that went on? If they say no, then continue on. If they say yes, then you say, okay, what did they do? If they say, well, they gave me this medicine or that medicine, I had a little bit of itching or something like that. And so that kind of gives us a heads up on to be watchful and some things that we might do, which we'll talk more about here in a minute. You want to make sure that you get a consent form signed. Giving blood, has to have consent, so you want to make sure that you do get the consent form signed. And here's my little consent form, if you can see now. Well, yeah, there you go. So our patient is Susie IQ Smart. So Susie has signed our consent form, and so that's our consent form with our information there. And so get that consent form signed. You want to look at H&H. Does it make sense that I'm getting ready to give this lady blood? So if her H&H is within normal limits, 14, her hemoglobin, does that make sense? But what I'm used to now, places may be different, but what I'm used to is anybody that is below 8 gets blood. So if they're 7.9, they're going to get blood. If they're 8.0, they're not going to get blood. But that's a hospital policy thing, so you need to be aware of your hospital policies. So I want to make sure I check that H&H. I want to make sure that I have a large bore needle, access needle in. So if they've just got like a 22 gauge, that's not sufficient. We can do it through a 20, not preferable, but can be done through a 20. 18 gauge is the most preferable. So I'm going to make sure that my patient has a bare minimum of 20 gauge, 18 gauge preferred, and I'm going to go in there, take my alcohol prep pad, swab off, and check it, the Heplock, make sure that it is patent, that I can get some blood return there, I can I can flush easily and all that kind of stuff. So, so we've verified that. I want to make sure that I take baseline vital signs. Baseline vital signs. You know, there's a couple of schools of thought. Some nurses take them before they go get the blood. Some nurses take them after they come back from the blood. I just take them both. I just go in there and, you know, take a set before I go down to get the blood and make sure everything's within normal limits. If anything's out of whack, you can't, there's no need in going and getting the blood because you can't give it to them until you get the vital signs within normal limits. Once I go get the blood and get back, I'm going to take a baseline set of vital signs there and document those and make sure that the patient is still within normal limits. Got to make sure that we have type and cross. Can't get any blood without the type and cross. So I'm going to make sure that my patient has a blood band on them. If they do not have a blood band on them, then we're going to stop the process. And we're going to know that something was wrong here because you know, I've got an order to give this patient blood, but the patient has no type and cross, they have no blood band on or anything like that. Type and cross has to be done every 72 hours. And it's not that your blood is going to change. It is simply the fact that when you type and cross for a patient, they're going to pull that blood product out and they're going to set it aside for that particular patient. So if you've not used it within 72 hours, it simply goes back into the main pool. So in order to keep that pulled out for that particular patient, every 72 hours you'll have to retype and cross. So we want to make sure that we've got our type and cross. Let's see, we want to make sure about medications. There's medications before and medications after. So what I like to do is when the doctor writes those orders or whatever, I always like to ask them, doctor, they're due for medications at this time, that time, whatever. Do you want me to hold those medications till after we're finished giving the blood? Or do you want me to go ahead and give those medications during the blood or before the blood or whatever the healthcare provider wants? Most of the time, the physician will then ask you, you know, what have they been on? Are they on anything new since they've been admitted here? So, for instance, if they've been on medications for their blood pressure, their heart, you know, respiratory, you know, whatever, diuretic, whatever, and they've been on that for years, doctor's probably going to be okay with us going ahead and giving that because if they've been on that for years, it's not likely that they would have a reaction to that medication while we're giving the blood. However, if they have been put on a new medication since they've been admitted to there or from another doctor within the last several days or whatever, then we need to know about that and let the physician know because they may sometimes when you take a medication, it doesn't react just because you take that first pill. Sometimes it has to build up over days, a therapeutic level, and that's when patients will start to react to something. So we don't want them on a new medication and be giving them a new medication while we're giving the blood product because if they started to have an allergic reaction or a reaction of some sort, we wouldn't know, is it the medication causing this or is it in fact the wrong blood or something in the blood happening. So in that case, new medications, the doctor's probably going to tell you to hold those until after the blood administration is finished and the patient is okay. So I think that's about it. So make sure that you assess those 8 things and know about that. Okay, so once you have done that, then you're going to have your requisition order. And so you're going to have a copy, and then of course the lab technician is going to have a copy. And so this is what you're going to take with you, go down there to the lab, get with the lab tech, and both of you are going to check all the information on this form. And so information on this form that you are going to check is what is the blood product that I'm giving? Is it whole blood? Is it packed red cells? Is it plasma? Is it albumin? Is it platelets? What am I giving? So I want to make sure of what I'm going after. I want to make sure that I've got the right patient name, their room number, hospital ID number, the doctor's name, the diagnosis. Does it make sense that I'm getting ready to give this patient blood? We want to make sure of expiration date when we get the blood, that we look and make sure the expiration date is good. We want to make sure that we look at the recipient's RH factor and the donor's RH factor, the recipient's blood type and the donor's blood type. So we want to make sure that those are compatible, that we can give that. We want to make sure of any other tests, all right, that we might have to have done before that we administer the blood. We want to check the blood bank unit number and the blood ID number. So there's a couple of numbers there, and those are a really big deal. So the blood type of recipient donor, RH factor recipient donor, and the identification numbers of the blood, all right, are really big deals that you want to check. Make sure that you do these 3 checks and check these numbers 3 times. Check them carefully. Look at number by number. Okay, everybody look number by number because it's easy for the brain to get fooled, for the eyes to get fooled, and you end up with the wrong blood. So we want to be very careful. So make sure that you check all of those. All right. So once you go over that with the lab person, and both of you verify, your label on your blood, and you verify that it matches this paperwork, then I want you to look at the blood and assess the quality of the blood to make sure nothing is wrong with the blood itself. So what we want to do is we want to look for things like frothy foaminess. If you see any frothy, foamy buildup in here, you don't want to accept that blood. It's going bad. If you look at the blood and it's not a nice, rich, dark red color, but it appears to have a purplish color to it, that is an indication the blood is going bad. You want to gently palpate in here and feel to see if there's any clumps or clots. So if you've got clumps or clots that you think you're feeling in there, the blood is bad. We can't accept that, can't give that to the patient. Also, I like to take it and turn it up and look along there and see if there's any black pepper-like sediment in there. And that is a good indicator of bacterial colonization. So I want to make sure of all of those. Seeing none of those and my paperwork, all my numbers, all my things that I have to check match up, and I've verified it with my lab person, then we're going to sign off on it. So it's got places for your signature and places for the lab person's signature. Now, once you receive the blood, and this is a policy thing, a little different between hospital and hospital, some will give you 15 minutes only to get the blood back to your unit, verify 2 more checks, 2 more safety checks, and get the blood infusing. Some will give you up to 30 minutes. So that's a policy thing, and you've got to know wherever you work what their time limit is. But once we do this and when I've signed for it, I'm going to go back and I'm going to get on the unit and I'm going to do a second check. So I'm going to get with another licensed personnel and I'm going to recheck all of this information that I just checked. So this is check number 2, all right? And we don't want to skip it. We want to make sure that we do this because we may have made a mistake with the lab person, and so if we have, we want to catch it before we do something wrong. So we're going to verify all of these numbers and all of the patient's name and all identification and all that and make sure it matches with the label on the blood. Also then, I like to tell students, if you are the one checking the blood on with another nurse, you want to make sure that you go back through and make sure they have consent form signed, they have an order to give it, the H&H, it makes sense that you're going to give this patient blood. All of those 8 things you need to verify yourself because you're a part of this with that other nurse. So it's 2 people here. So you're a part of that too. So you want to make sure that you do a good job and that you assess all those kinds of things too. All right, for our third check, then our third safety check, we're going to take our paperwork, we're going to take our blood, and we're going to go into the patient, and we're going to verify everything by the patient's blood bands and hospital ID bands that are on the patient and ask them their name, verify by 2 means, and we're going to make sure that the numbers on their bands match what's on the blood and matches the paperwork. So that is our third and final check there. So once we've done all those safety checks, and you have another licensed personnel with you in that room verifying all this, so it's 2 people there. Then once you get done, you're going to sign that off. And so now we've got our safety checks done. Okay, so what I need to have is for my supplies is I've got to have an IV pole with a pump. I'm not going to demonstrate the pump because it's getting this video is going to be too long. Read the directions on your pump. Every pump is different. If you'll just read the directions, the pumps are self-explanatory. That's what I've found. But anyway, having said that, you will need a what we call a blood Y tubing. I think you can see it there a little bit. Okay, blood Y tubing set. And of course you need your blood product. Okay, so I'm going to get rid of this. And as with IVs, the first thing that you need to do when you get tubing out, any kind of tubing, I don't care what it is, it's going to be wide open. So the first things you want to do when you get tubing out is you want to close off the regulator. Okay, in blood Y tubing, the reason they call it Y tubing is because it looks like a Y. When you hold it up, it actually has a place to spike saline and a place to spike your blood. So this has 2 clamps right here. So you've got to shut off 2 roller clamps. So 1, 2. Then you have a main regulator clamp down here. So that's a 3rd clamp that you have to close off. Okay, so make sure you close all 3 of those off. You will also need a pair of gloves for when you spike the blood. You know, the rule says if there's the potential for you to come in contact with a blood or body fluid, that you need appropriate PPE on. And there is that potential when we spike the blood, that blood could squirt out, something could go wrong, and we could get some blood on us. So we're going to take appropriate precautions. All right, I also want you to see, yes, this is showing up good here, at least on my TV that I can see. You can see this big white thing. So here's a drip chamber. This is our drip chamber, just like a regular IV. This in here, this big white thing is a filter. And when I spike the saline and open the saline to purge the line, I have to get that saline all the way up over top of this big white filter here. And make sure that you keep solution over the top of the filter. There's a reason why. You don't want the blood coming down and dropping and hitting that hard plastic top because that will rupture the blood cells and will not do the patient any good. So make sure you monitor that and keep your solutions over that. So I'm going to go ahead and don my gloves. Okay, and I'm going to go ahead and spike my saline. So I've got saline. This is sterile. This is sterile when I pull the top off. So you want to make sure you don't touch those with anything unsterile and bring those 2 sterile ends together. All right, and hang it up. There, so now I've got my saline. And so now I'm going to spike my blood. And I'll pop the top off there. So that's sterile end. Don't want to touch that with anything contaminated. Here's the sterile end. So I've got my cap off now. I'm going to bring the 2 sterile components together and put that in there. Okay. So now I'm ready to get this adjusted and get this set. I'm gonna move my junk out of the way there. Okay, so what I want to do is, again, just like a regular IV, this line, this drip chamber and all this is full with air, and so we've got to purge that air out of here. So what I'm going to do is pull the top off there, protecting those, make sure it stays sterile. I'm going to open the saline. Now, interesting thing, pay attention to this. Only one of these can be open at a time. If you open both of them at the same time, the blood will usually run down and then get sucked right back up into your saline bag, and you don't want that to happen. So keep one clamp closed while the other one is open. So they're both closed right now. I'm going to go ahead and open my saline. Now nothing's running yet because the primary regulator down here is closed off too, so nothing's running. So what I'm going to do is squeeze my drip chamber and start pulling solution, and you can see the solution there getting pulled down in there. And I'm going to keep squeezing my drip chamber until I get solution over the top of my filter, and that looks like that's a good deal right there. And so then I'm just going to open my regulator and start priming my line, and it's coming through. I'm just running it a little slow. All right, and so I've got some coming out at the end. All right, so I've purged my line and got that done. So what I want to do now is I'm getting ready to hook it up and everything. I'm going to put it in the pump and all that kind of stuff. So I'm going to close my saline off. All right, so I've got both of them closed again. Now I'm going to open up my blood. Okay, so I open up the blood, nothing's running because my primary regulator is still closed off. And so what I'm going to do is just give a quick squeeze and pull the blood down there. So now I've got blood, you can see in here, and it's at the top of my drip chamber, and I've got plenty of solution over top of that. I like to go ahead and then purge my line again to get the blood down there. So I usually go ahead and open this up one more time. It's going to fight me here. And get that going through there. And of course, this is a little bit light, so it's hard to see that the blood, that the red tint is going through on the TV. But anyway, I go ahead and run the blood through there, get it all the way down in my tubing, up to about right there. Don't let any blood run out into the trash can or anything like that. Don't do that. But run it down to about the hard plastic surface there. All right, and so then I'm going to set my pump, get this in the pump. Just follow the directions like I said and get it in your pump so you're ready to go there. Then you're going to open up. We've already checked this by flushing it and that, so we're going to swab this off. And connect that together. And if you need to, you can put a piece of tape on it or whatever you need to do. But we're going to go ahead and get it running. So I'm going to start my pump, and I'm going to run it very, very slowly. The first 15 minutes, we're only going to run it about 50 cc's an hour. And so the patient's going to get very little bit of this blood in 15 minutes. And so what we're going to do is we're going to stay with the patient and monitor the patient for that first 15 minutes. So you cannot leave the room, you cannot leave your patient for that first 15 minutes. Set your pump to run at 50 cc's an hour and stay with the patient for 15 minutes. I think I calculated it once out, and I think that comes like to 12 milliliters in that 15 minutes is all they're going to get. So think about a 30 milliliter dose cup that you give your children's dime tap in, or whatever you give, Tylenol or whatever. The 30 milliliter dose cup. So this is only 12 milliliters, so it's a very small amount that actually goes in them. And so at the end of that 15 minutes, I'm going to take their vital signs again and compare them to my baseline before I started. If everything is looking good, I'm going to ask my patient, are you feeling okay? Do you have any back pain? Are you feeling any chest tightness, chest pain, having a smothering? Are you itching anywhere? Do you feel any headache developing or anything like that? I'll talk more about those signs and symptoms here in a minute. But once that, if there's answers, all the answers are no on that, and the vital signs are good, I'm going to go ahead and bump up the rate then to whatever it needs to be to run in per the doctor's orders or by a maximum time length of 4 hours. That's what you've got. So periodically then, while the blood is running, after that first 15 minutes and everything is good, I can leave the room, go take care of my other patients and stuff, but you're just going to come back periodically depending on the hospital's policies and recheck those vital signs, check on your patient, make sure everything's going good while the blood is running. Once the blood finishes running, okay, here's what we're going to do. The bag is empty, but there'll probably be still some blood in the tubing down through here, all right? And I want the patient to get all that blood, that they need. So what I'm going to do is I'm going to turn off the blood, and I'm going to open the saline and let the saline run at the same amount that the blood was running, all right, because it's still just pushing the blood. So whatever I had my pump set on, I'm just going to let that go ahead and flush. I'm not going to let this whole bag run in. Absolutely not, because this is going to be taxing enough on the patient's body. Fluid volume overload becomes a potential threat there. So we want the blood to go in. We don't want this saline, much of this saline to go in at all. Basically, the saline is just to prime the line with and keep the blood from sticking to the sides of the tubes. So once the blood gets all in out of the tube, I'm going to shut the whole thing off and disconnect. All right, send the product, and hospital policies are different. They may want the whole thing back. So where I worked, we put the whole thing in a biohazard bag and we took it back to them, or sent it back to them. And that way they kept the tubing, they kept everything. If something went wrong, they could, you don't know, it could have been a contaminated tubing. It might not have been wrong blood. It could have been contaminated saline. It could have been contaminated tubing. Could have been anything. So they swab and check everything. But if nothing goes wrong, then they get rid of it after, so many days. Okay, I'm going to try to wrap up. If you suspect the patient is having any type of reaction, all right, if you even suspect, oh no, I think this is not good, first thing to do is just shut the blood off. That's the number one thing. So if after that 15 minutes, first 15 minutes, they're starting to say, my chest is getting tight, I'm smothering, I'm itching, you see them breaking out in red welts or anything like that, then stop that blood. Okay, let me hit a couple more things. Only hang blood with saline, nothing else, okay? Never hang blood with anything else. It is not compatible with anything else. It will cause problems. So normal saline is the only thing you can hang blood with. After people get blood, if they're elderly or their heart's not quite as strong, they may have a little bit of fluid congestion develop in the lungs from fluid volume overload. This goes back to medications. Sometimes the doctors will leave you orders for Lasix or furosemide, furosemide, IV push. You can push that and they'll just kind of pee it out. If a patient has had blood before and they have a little sensitivity reaction to it, most of the doctors just do this anyway. Prior to administering blood, they'll give you orders to administer 50 milligrams of Benadryl, diphenhydramine, and 1,000 milligrams of acetaminophen. And that just, sometimes patients will have a sensitivity to a blood product. It's not that full-blown hemolytic reaction of wrong blood. It's not a big blown allergic reaction. It's just a sensitivity to the blood, something in the blood, the preservative, something. So a lot of doctors will just go ahead and give that. That will not mask the signs and symptoms of the full-blown reaction. So you don't have to worry about that. All right, and I think that's all I wanted to tell you. So I hope this video does good for you. And of course, if you have questions, contact me on our discussion board and ask anything that you might need. And I miss you all. Wished I could see you all, but maybe we'll get through this. All right. Thanks, guys.